This panel discussion is going to look at a topic I think the families know well, and that's phenotypic variability in Duchenne. But this is something that can have profound implications for how we manage the disease and how we develop therapies. So we have to move toward better understanding the factors behind phenotypic variability in Duchenne muscular dystrophy. So we put this panel together to talk about this from a number of different perspectives. So I'm going to let folks go through, and Enrique, if you want to introduce themselves. And the way we're going to structure this is that some of the folks on the panel are going to speak for 5-10 minutes, and we'll have some questions, and then we'll open it up to any of your questions. Okay?
Hello, everyone. I'm Enrique Avilés. I'm the Chief Technology Officer and Director of Data Standards and Management for Critical Path Institute, a nonprofit that is in partnership with PPMD.
I'm Craig McDonald from University of California at Davis. I've been involved in Duchenne muscular dystrophy natural history studies and clinical trials.
My name is James Signorovich, and I'm a Vice President at Analysis Group and a member of the TAP collaboration, which you'll hear more about shortly.
I'm Brenda Wong from Cincinnati Children's. I'm a clinician involved in the care of boys and young men with Duchenne muscular dystrophy and other types of neuromuscular disorders.
I'm Dan Sheehan. I'm a pediatric pulmonologist from Women and Children's Hospital of Buffalo.
Hi, I'm Catherine Wagner. I'm the director of the Center for Genetic Muscle Disorders at Kennedy Krieger. My research is on muscle regeneration and novel therapeutics for muscular dystrophies.
Great, thanks. So just to frame this a bit, as I said, phenotypic variability is pretty much a given in Duchenne, and it's even common among patients that share the identical genetic mutations. So there isn't necessarily a primary gene association with this, but the known knowns, I hate to quote Donald Rumsfeld, but the known knowns are really few. So steroid status certainly has something to do with the phenotypic variability. And there's been a couple of modifier genes that have been identified, and we've heard about them from this stage over the years. I think SPP1 or osteopontin and LTBP4, both are rather potent modifiers. And I think the suggestion with modifier genes is that we've probably only begun to scratch the surface in understanding how genetic variation in other genes influences the phenotype that you get from any particular dystrophin mutation. So the really critical thing here is that this phenotypic variability then becomes yet another variable that we have to worry about in clinical trials. So we have, variability in patient care that can certainly influence across different trial sites and a number of other factors, but this is one other thing that we're going to have to consider. So it's a critical gap, and as you know, PPMD likes to address critical gaps in knowing what lies behind this variability. So we really need strategies, and actually the panel is going to talk about the full gamut of this. To understand, we need strategies to understand the factors that will predict the clinical course and the severity of the disease with the greatest accuracy so that we know what's behind it and we can factor it into clinical trials. So the questions that I think are out there is, how can we understand the patterns of phenotypic variability in Duchenne? I'll come back to these later. I'm just going to throw them out there now, and we'll go through each person presenting, but we'll come back to these. What are the implications for phenotypic variability for clinical trials? As I just said, it could have a profound effect. What are the known factors, and particularly the mechanisms that underlie this variability? And then finally, how are we going to go about determining what other factors contribute to the variability, and how can we model that to account for its use in future clinical trials? And do we have the tools to do that? Do we have the data to ask those kinds of questions? So as I say, we'll come back to these questions. I wanted to throw them out there for you guys to think about, for the panel to think about. But I think we first up have Craig and I'll come back to that.
Great, thanks, John. I'd like to just spend a couple of minutes discussing what we've learned from natural history studies with regard to phenotypic variability. First of all, I think it's important to keep in mind that there is inherent variability in disease progression and also variability in standard of care. And these are perhaps more important contributors to variability that is encountered in clinical trials than the issue of reproducibility of the actual endpoints employed. I think we see variability in clinical trials, and I think we're quick to blame that variability on the endpoints, but there's actually really quite a bit of variability in standard of care and also variability in disease progression. And just to focus here on the 6-minute walk test, there on the left you can see before the age of 7 there's actually both in typically developing children and boys with Duchenne, there's a maturational effect, an improvement in 6-minute walk distance. But over on the right, that's the placebo data from the Adelurin trial. You can see there are some patients that actually exhibited very slow disease progression, and there's other patients that actually exhibit very rapid disease progression. And I think this variability is not just seen in the 6-minute walk test, it's actually seen in all the endpoints, the time function test, the North Star, and that variability can be due to variability in steroid regiments, genetics and polymorphisms, and also the issue of baseline level of function and disease severity, which predicts future disease course. I think what we're learning with some of the dystrophin restoration strategies is the longer-term follow-up when we start following these boys in clinical trials over 2 to 3 years. This really gives us much more assurance that the apparent treatment effects are real because the disease progression becomes much more predictable. Now here's actually data from the Synergy network on forced stair climb velocity. You've been hearing a lot about this as an endpoint. We now have 1-year longitudinal data. I'm showing here 2-year longitudinal data on stair climb velocities by age in steroid-treated Duchenne patients. We now have 3-year longitudinal data. And you can see that in the very young patients, we're able to measure this endpoint. But also you see that early on, before the age of 6, there's actually an increase or an improvement in the velocity that occurs over time. That improvement actually decreases over time, but by the time these patients reach an age of 6 to 7, you can see very predictably over time there's a slowing of velocity that occurs over 2 years on this endpoint. And you're seeing an increased number of clinical trials now that are using the forced stair climb as an endpoint, which I think is an exciting change. Here's similar data on the 10-meter walk-run velocity. And again, this is 2-year longitudinal data in steroid-treated patients. And you can again see we're able to get this endpoint in some very young children. You can see a slowing of velocity that occurs over time. And by the time these patients are 6 years of age, again, a very predictable actual slowing in velocity over time. So if you see stabilization of velocity or even improvement in velocity, and it's a longer-term follow-up, you can be fairly sure that's a treatment effect and not a drug effect. Now, the other important point is that baseline severity really predicts future disease progression. And just an example, this is data on standing time and how many patients subsequently lose the ability to ambulate. The red actually shows the percentage of patients who can't stand any longer. They can't get up from the floor from a Gowers. And the percentages that lose ambulation over time. The other curves show a relative maintenance of ambulation in those who are able to actually get up from the floor. But again, even in that red curve, you can see that even at 24 months out, there's about 40% of patients who were unable to stand who still maintain the ability to ambulate. And that's variability in disease progression. Here's again forced stair climb and prediction of subsequent loss of ambulation. So those who can't climb stairs, a high percentage of those patients will lose the ability to ambulate over 24 months. But again, a baseline value of whether you're able to do the stair climb in less than 8 seconds or greater than 8 seconds also can be predictive. So again, disease severity is predictive of subsequent disease progression. And here's our data we're soon to publish on the 10-meter walk-run velocity. And again, when you have time to walk around 10 meters less than 6 seconds versus those that are greater than 12 seconds, you can see a fairly predictable impairment that occurs in terms of ability to continue ambulating. And then finally, when you follow patients over longer periods of time, say 4 years, when you follow, the red shows those who actually had a 10% decline in function over the first year of follow-up, and that actually is predictive of loss of ambulation over 4 years in comparison to those patients who don't decline by 10% over a year's time. And then finally, even when looking at pulmonary function, this is data that actually came out of a natural history study from France, actually looking at age at loss of ambulation and its effect on subsequent pulmonary function. And you can see on the right there that those young men that actually lost ambulation over the age of 11 actually subsequently developed a much higher level of forced vital capacity, and they had a slower decline in their forced vital capacity. Again, this is variability in disease progression. We've got some patients losing ambulation younger than 8, some patients losing ambulation after age 11, and you can see differences in subsequent disease progression and slopes that occur. So again, but the baseline value can be quite predictive and useful. Now, steroid regimens create variability. And Luca Bella actually has this paper actually in press. He's presented at the American Academy of Neurology, and this was data from our Synergy Natural History study showing those patients who were on different steroid regimens. And the green are those of patients who were on daily deflazacort versus those patients who were on daily prednisone, intermittent prednisone, and weekend prednisone. And the median age loss of ambulation was 11.2 years in daily prednisone versus those taking daily deflazacort. The median age at loss of ambulation was 13.9 years, highly significant. You could postulate what this might be due to, but the patients generally had higher doses maintained closer to the therapeutic window on deflazacort, whereas those on other regimens had reductions in their dosages over time. And then finally, genetic polymorphisms create variability, and we've learned this again from the natural history study. This is data looking at the genetic polymorphism, the LTBP4 genotype, and if you look at the bottom two curves, the darker line there actually shows the age at loss of ambulation in those that have actually a more benign genetic polymorphism, a more benign genotype on that LTBP4 polymorphism. And this is a regulator of TGF-beta and inflammation, and so it actually makes sense that this polymorphism would actually ultimately explain disease progression. And in fact, on the lower right, you can see the combination of steroids in the solid curves versus those who are not on steroids has a big difference in terms of subsequent loss of ambulation. So I think the natural history studies are helping us to get some handle on these issues of variability. I think it's going to help with regard to clinical trial planning, but you're going to hear more exciting efforts in terms of combining some of these data sets to allow us to learn even more.
Hey, Craig, just one. Just while you're there, so just looking at your error bars, at the variability and what was it, the 4-step velocity. Mm-hmm. So how is that? Just can you explain how that's impacted things like powering for clinical trials? That you have that degree of variability?
Yeah, I mean, obviously, you look at those error bars, those box and whisker plots. You know, the green arrows there on the steroid treated are really where 75% of the patients lie. Those error bars are really the ends of the distribution. And so that certainly affects your so-called signal-to-noise ratio. And the more you can actually improve your signal and reduce the noise, the more that is going to be beneficial, obviously, in powering a clinical trial. But I think we've been working with these companies that are focusing on the 4 to 7-year-old non-steroid treated patients with endpoints such as the 4-stair climb, and it actually has led to powering, which is pretty surprising in terms of the relative small size of these trials in terms of statistical power. So I think focusing on some of these endpoints, when we look at a medication that has fairly potent acute effects, like prednisone or deflazacort, or some of these NF-kappa B pathway agents, I think we're probably going to see fairly acute effects over a very short time course of, say, 6 months, so allow for shorter trials.
So just to put the piece of information out there, with that age range using the 4-step climb, how many subjects do you need in a clinical trial to appropriately power?
Again, I think it really depends on the effect size that you're after. But I think these trials are probably on the order of probably going to be looking on the order of 30 subjects per treatment arm. Not profoundly large trials, but we'll see as we get more experience with this endpoint and with the conduct of some of these trials. Also, these patients are going to be steroid naive, and so that also helps in terms of some of the variability issues because they're not on multiple different steroid regimens.
Yeah. So anyone else on the panel have any questions, comments about this characterization of the phenotype that Craig has just worked through? No? Okay. So do you want to go next? You want to go up? It doesn't matter to me. You can do it from here or whatever you'd like to do.
I think I'll be lazy. I'll stand up.
Okay.
I would just like share about 5 minutes from a clinician's perspective. So basically, you're right that there's phenotypic variability, just knowing that without steroids, age of loss of ambulation ranges from 5.5, 6 to 12. And with steroids, that moves that whole the age range from 8 to 20. So really, you still see a kid that can be started on steroids at age 4 or 5 and yet not be walking at 8, and there is another one that walks till 20. So we see that in clinic. And in clinic, too, we would have this comment about, this kid is strong but tight. And that kid is just very hypotonic and seem to be weaker. And I think you see a lot of the real hypotonic, excessive range of motion, the kids that age 15 that's been on steroids and still pretty weak. So we don't know why there is a strong and tight and the floppy and weak. An example for the floppy and weak, I think we have one patient who had like a in-frame mutation, but clinically you think he's a Duchenne's, like at age 5, because he had all the motor difficulties and the Gowers. So we weren't sure. And so when you start treating with steroids, they get better, but then after a while, you kind of start to wonder if his hypotonia got better and it's really the steroids of him. And of course, we do MRIs, and there was no fatty infiltration after 3 years. And so muscle biopsy, and I was like, okay, there is a little bit of dystrophin, but clinically he seemed to be pretty atypical for Duchenne's. And so I think we took out the steroids and he's still fine. So I think in that case it exemplifies the fact that his early years of hypotonia probably was associated with the motor difficulties like the difficult running and the stepping and stuff. So we don't know. So that's exactly what we see in clinic. And then the next few minutes, I will try to address your topics of origins, how to measure and factor variability into clinical trials. I think origins, Craig and John has mentioned about the inherent genotype. So you have the genetic part plus the genetic modifiers. I would just like to throw in from my clinical experience just a few observations to see whether that is something that will be brought forward, because it's usually the N of 1 that we see in clinic that leads to more studies, and then that leads to the results that we see later. So there are some mutations that seem to be associated with a milder phenotype. I think for those of our families who have the deletions 3 to 7, you will see that we have been labeling them with DMD intermediate, and they tend to go away with tolerating a lower dose of steroids. And in fact, that's the group that you find like walking till 19 and 20. And if you look into the family history of that group, really there are some family members that's like Becker's phenotype as well. So I think the deletion 3 to 7 has been reported in the literature about that exon 8. issues. So I think that's the group where we have been able to spare the steroid dose and enable them to continue doing well, and they're still walking like 16, 17, taking public transportation to school in high school. So I think that's one group. I think the other one, I'm not sure, but it's just in clinic that the duplication twos, they seem to be stronger, but their heart's not too good because one of our cardiac transplants that's now seeing Linda is a duplication 2. We have another couple of duplication 2s. EF is 45%. So not sure, but that's something to look at. And then our deletion 45s, I think you all are aware, the exon 44 skipping group, that delay in the trials because it was found that at baseline they have, 3% dystrophin instead of 0, and that kind of resulted in the need for a better assay for dystrophin. So I think in our clinic, I would say that a number of our deletion 45s are the milder phenotypes, and there is still one kid, I do remember, a deletion 45 that lost ambulation at 10 on steroids. So we still don't know why. It's not everybody. But that's just an observation. Then, of course, in clinic, we diagnose Duchenne's by definition of the clinical phenotype, presenting with Gowers, difficulty walking, and, when they're age 3 to 5 and 6. So that technically includes a number of our large in-frame deletions. And you see that maybe a lot of our kids that's walking to 20, they're large in-frame deletions, but even with steroids starting like at age 10, they still lose ambulation at 13. So we know they are not backers by definition because they lost ambulation like at 13 instead of 16. So I think that probably kind of would be the inherent part of it. And I think the other thing is the role of eutrophin, right? Because I think if you look at the muscle biopsies of some Duchenne's where they have no dystrophin on muscle biopsy and he's like totally looking normal at age 8 on steroids, that kid had a lot of eutrophin. And then the other kid that like was waddling and really looking severe with some traces of the dystrophin 1, he had no eutrophin. So I don't know whether that's something that we will look at. And of course, the milder phenotypes, the deletion 3 to 7s, if you look at the muscle biopsy for the immunohistochemistry, by and large, the milder phenotypes has a little bit of mild staining to dystrophin 1 rod. And the dystrophin 2 usually is absent. But the Western blot by Athena is always absent. So I think that may be something to look into. Then, of course, the other factors that would be under our control for us to standardize would be the steroid regimes, because the 10 days on, 10 days off versus the daily prednisone from the London group. Prof. Dubowitz and Montoni in London has done 10 days on, 10 days off for 25 years, 30 years, for a long time. But I think because of this concern for side effects for daily, they still do 10 days on and 10 days off. But for their data that they have done, the mean age of loss of ambulation for 10 days on, 10 days off, 12. Daily prednisone's 14.5. And clinically, in clinic too, we see that. You see that the 10 days on, 10 days off, by the time they're 8 or 9, you have to push them to daily. So 80% of our kids that I started on 10 days on, 10 days off in the year 1999, 2000, would move on to daily within like 2 years. So I think the steroid regimes will be one to standardize. And then that's another 2 clinical factors that we've seen that affects motor function, and that has been shown by data in one of our abstracts for the world muscle, would be the impact of BMI. So you can see that if your BMI is greater than 85th percentile, i.e. you're overweight, or you're greater than 95th percentile, there's this correlation with your times for your time function test. And we also did look at our PUL scores and BMI, and that's also affected by the BMI. We had a poster there yesterday, this time round for the PUL. And the range of motion, we too had posters for world muscle that showed that the presence of ankle and knee contractures correlated with a different rate of decline. So for our data that we had for follow-up of 7 to 9 years, you can see that those boys with contractures actually has a faster rate of decline than those boys who do not. So I think those are the factors that if you're aware of, you do your stretching, you maintain your range of motion, and that one would help, and that can be controlled for. As regards to factoring the variability, the measures, how to measure, I think as what Craig has shared, those time function tests that we easily do in clinic for assessing our boys, we look at the times as well, and we can actually predict just by looking at the numbers or the North Star scores or the PUL scores, like what you are going to expect clinically. Like Craig has said, the 6 seconds is that 10 meters, 6 seconds. Normally when they run, they do like 3 seconds, 4 seconds. They stay there for quite a while, and then once they hit 6 seconds, the group that has got a more severe phenotype, you can tell that they're going to be off their feet in about 1 to 2 years. But that 6 seconds, the milder phenotype can keep on that 6 seconds for about 4 years. So that evidently in clinic, we can see that difference. And then how do we factor the variability for trials? I think what we did for the IGF-1 study was trying to get this homogeneous group. And I think, one, if you could select your age group, like say 6 to 10, and then place on your criteria for your times, for time function, you'll be getting like, okay, 6 to 10, you want a North Star score of like in the 20s, and that will be that age group and the scores, because if you've got a more severe 6 to 10, your scores are going to look worse than that. Like the four-stair climb, a 6 to 10-year-old, for those of us on steroids, they are all climbing up in less than 2.5 seconds. But the more involved ones and the more severe phenotype, they are going up in 4 seconds, 6 seconds. So I think if we keep that age together with your criteria, you probably may get a tighter group. So for our IGF-1 study, we did within that range, and so they were quite comparable. That's just from a clinician's perspective. Not sure if that's right.
Any comments? Any comments or questions from anybody else on the panel on what Brenda just had to say?
I'd be happy to.
Brenda, with regard to the contracture issue, I completely agree. Ankle contractures are oftentimes can have an impact and are actually perhaps an indicator of more rapid disease progression, more severe disease. But when you look at some of the other joint contractures, such as elbow flexion contractures, hip contractures, and knee flexion contractures, those oftentimes don't really start to become progressive and relentless until after boys are sitting more and have transition. So those almost seem to be secondary phenomenon in the setting of less than anti-gravity muscle strength, where you can't put yourself through your full range of motion. But what are your thoughts in terms of the issue of contractures as secondary issues to more static positioning in a wheelchair? What do you do to try to prevent those contractures once young men are spending more time off their feet?
I think for the non-ambulatory kids, you're absolutely right. The development of the lower extremity contractures just progress really fast. In terms of preventing, I mean, a lot of stretchers, I think it's a losing battle for the non-ambulatory, but what I'm referring to, it's really the ambulatory kids, because we find that there's some kids with very, very tight hamstrings, and the popliteal angles, if they're if they don't take care of stretching those hamstrings, and their popliteal angles go to like 60 degrees, they start getting like a 5-degree knee flexion contracture, and then when they get really fatigued, they just have sudden falls. They would stand, and if the quads are not strong enough and they're really fatigued with the 5-degree knee, and those are the kids that just, for some, no reason, they just stand there and they're tired and they drop. And we find that if we actually get them to really work hard on the hamstring stretchers, that may help. So I think for the non-ambulatory, it's really hard. I think there's no way we can fight that progression. But the upper extremity contractures will be important for the PUL because I think that does affect the scoring. So I think that's more for the upper extremity non-ambulatory trials.
So let me first comment about contractures, but just to broaden it, that when we're talking about variability, we're talking about variability in terms of changes of strength, in terms of tendons or range of motion and contractures. Cardiac function, Brenda mentioned, which I'm particularly impressed with, seeing the adults with the huge variability and cardiomyopathy. And then certainly cognitive, psychosocial, is also huge variability, from kids who are adults who are not making eye contact with me and kids who are going to college. So, really lots of variability. And we're all tempted to say whether this is nature or nurture, and maybe that's part of the question also with the contractures. Is this environmental or is this genetic? And it can't be divided into one or the other. Of course, it's both. And I do believe that with the contractures, that yes, you're right, certainly, Craig, that when you're sitting, you're going to develop contractures more quickly. But there's in my mind, there's no doubt that there's a genetic component too. That, for instance, the fingers, you can't ascribe that to sitting. There are kids who have been sitting in a wheelchair for 10 years who've got great range of motion in their fingers, and others who become contracted very early. So. These are really difficult things to tease out. I think Stan Nelson's attempts to look at both the environmental influences, the drugs kids have been taking, and in addition looking at the whole exome sequencing for modifier and genes is a really wonderful approach, and I'm sorry that he escaped early and isn't on this panel. Can I make another comment, or would you like to move on?
Ahead.
Okay. Another theme that's developing from our first two speakers is variability, and how do we deal with that in clinical trials? There are two potential approaches that we can take as a community. One is to take very small subsets of patients with very limited inclusion and exclusion criteria, or to take much larger sample sizes and control for this variability. And we've seen examples of both of those over the past few days by some of the clinical trials. Obviously, the large trials have the disadvantage in that they're going to use a lot of patients, and we have a lot of different things that we want to trial, and they're expensive. But I'm certainly more in favor of the latter because of what we learned then about the generality, how we can generalize the findings. If we take a very small subset of patients and we say, okay, you have to have had this type of decline, and you have to be doing this age and on such and much medications, then can we... Can we generalize that to the whole population? And I think we're already seeing some issues with that. I'm personally excited about Adebinone. Can I generalize what we've seen? We've seen, and there will be more studies, so hopefully we will learn those answers. But can we generalize what we've seen to kids who are already on steroids? Can we generalize that to younger kids? And I think the FDA guidance is asking us now to not take smaller subsets, but to broaden.
So actually, it's kind of interesting. This is the slide I flashed by, and I think one of the challenges, give me a second, one of the challenges is that we not let our identification of early and predictive criteria, we need to be careful how they're used, because we don't want them to further fragment the population for clinical trials. I mean, I think that's one thing we need to be... I'm really interested in this topic and what's behind variability, but whatever tools we design, and we're going to be getting to that, we need to be careful about how they're implemented, because this is where I thought you were going, that it might be fragmenting, that it could lead to fragmenting the population even more for clinical trials, which may lead to labels that are specific for subpopulations, which I don't think this field wants to go
so you mean
in that direction.
By labeling also, do you mean labeling of drugs?
Yes,
that
that's
we
what
say,
I mean.
this drug is approved for and therefore paid for by insurance for this very small subset, when it might actually be useful for an entire group if the clinical trial was conducted that way.
Sorry, go ahead.
Just one comment. I just would like to remind us that the FDA guidance paper specifically encourages sponsors to enrich the trial population for those who actually can respond. So you can and you're encouraged to narrow down the number of patients who enroll in the trial and focus on those who you can expect that they do respond in order to save time and also come up with smaller trials. So I just would like to say that this is, I think, an encouraging move of the FDA to make sure that we can run trials more quick and have more informative, although in a narrow population. So I remember way back when we planned the Delos trial, we were told by the FDA we should enrich the population for those patients who are in the declining phase of the respiratory function, because Russell Kotz at the time said, we would like you to demonstrate that your drug actually stabilizes against the rapid drop of PEF, in this particular case, so peak expiratory flow. So I think just bear in mind the recent guidance paper clearly encourages sponsors to enrich populations or trial populations to those who actually can reply or respond. And that means that it would be smaller trials, but more specific to certain subgroups of patients.
Thanks, Thomas. Okay, Dan.
Is there a pointer or no? Yeah, the button. This one? Okay. So in 5 minutes, I'm going to aim to show 5 studies that show the phenotypic variability that occurs in Duchenne muscular dystrophy. And they're going to be presented and kind of framed from discussions and conversations that I've had with Dr. David Bernkrantz, who's been very involved in the care considerations, but has also studied closely brothers in Cleveland who have the same mutation but have very different phenotypes, as well as a paper that he'll be publishing in the next year about prolonged survivors, individuals who are steroid naive, who are living into their 30s, and what's different about them. And so,
green button.
Thank you. And so as I present these, I want you to try and think of these potential future studies. Are there cardiac muscle modifier genes and skeletal muscle modifier genes in these steroid-naive prolonged survivors, as well as siblings who have very different cardiac and very different pulmonary function? And then in addition, what are the mutations and modifier genes of responders and non-responders? I also work in the world of cystic fibrosis, and many of our patients are on every single imaginable drugs, and what we haven't done a good job on is describing for an individual person, have we really provide personalized medicine, where if we know they're a non-responder, do we take them off of that medication? I think it's thrilling that we have so many potential medications for Duchenne, but there's responders and there's non-responders. I think it'll be important to define non-responders. Okay, so as I reviewed the studies, there is great pulmonary phenotypic variability. In steroid naive, it does seem like the age of loss of ambulation is predictive of the rate of decline of FVC percent predicted. So it's going to be very important to have run-in data so you start to get a sense of what somebody's individual slope is. Genotyping to date does not predict pulmonary phenotype. There's really data lacking regarding the impact on steroids on pulmonary phenotype and genotype. And then, siblings can be discordant in both pulmonary and cardiac phenotypes. One of the earliest studies was back in 1981 by Rideau. And what you see on the y-axis is vital capacity, the total amount that you can blow out after breathing all the way in. And if you look here, what you can see is that initially there's not a lot of phenotypic variability, but as individuals age, you get a wide phenotypic variability. And he looked a little bit closer, and his group was the first one that described possibly the three different phenotypes. If we, back is here? Okay. I don't play video games, so I'm not very good with pointers. If we look in the lower left-hand corner, he described three phenotypes, and I think these are individual patients. On the y-axis, you have vital capacity. On the x-axis, you have age. And you can see that the individual who lost ambulation at age 8 achieves a lower value and then a more rapid decline. This other type that loses their ambulation a little bit later reaches a higher and may or may not have much of a decline. And then the individual that lost ambulation at age 10 is probably somewhere in between. And I think Craig had already shown this figure here. And this was from France, over 200 patients. This is, I'm going to get this right. I'm embarrassing my children who play video games all day. In the lower left-hand corner was what Craig had shown. And you can see that the individuals that lost ambulation between 11 and 16, between 8 and 11, and before 8 were very, very different. But if you look at the percent predicted, each one of them seems to have a different curve. So it would be great if there was some run-in data before clinical trials to see what potentially is the path of this individual. You know, I missed the 1980s with research where you got to see the individual curves. These days we see a lot of means and standard deviations, and I think it's really going to be important to look at individuals to see if they're responders or non-responders. Okay, what about siblings with the same phenotype? Dr. Bernkrant looked at 7 brothers in Cleveland and found that 3 of the 7 were very discordant or very different with their pulmonary phenotype. This is an example. Instead of patient 1, patient 2, this is brother 1, brother 2, the FVC and leaders. You can see one brother went up to a very high level and stayed constant, and the other brother, went up and then had kind of more of that intermediate. And, I think you just got to keep in mind that brothers may be very, very different, and may be worthwhile taking a step back and looking at why brothers are different. MD StarNet, I've been working with MD StarNet for about 4 to 5 years. We also looked at siblings, kind of a busy slide, but we looked at cardiomyopathy onset described by echocardiogram, by ejection fraction or shortening fraction. We looked at 19 brothers, and you can see that the median age difference is around 2 years and 1 month before they, as far as the difference in when they achieved cardiomyopathy onset. But, there's great variability. It may be as much as 11 years or even 7 to 11 years. Well, what about corticosteroids? Well, this is from the Synergy group. I'm going to show you the exact same slide, but I put some lines on it. So on the y-axis, you have the FVC percent predicted, and then you have individuals who are naive at 7 to 9 years of age, 10 to 12, 13 to 15, 16 to 18. And then you have those that are currently on steroids. And you've got a number of different ends for each of the points. And so the blue line are those that were steroid naive, and the green line are those that are currently on steroids. And you can see they have a very different path. But what I don't see is I don't see a tightening of that standard deviation or the variation. So probably within there are probably some individuals that have maybe a minimal response, and probably individuals that have a great response to steroids. So again, great pulmonary phenotypic variability, percent predicted of FVC. It'd be great to have some run-in and run-out data for clinical trials. We're still not there with genotyping. We lack data on the impact of steroids on pulmonary phenotype and genotype, and I think there's probably enough siblings and brothers out there to go back and take a close look and see why they're different.
Great. Thanks, Dan. Any comments, questions? No?
The data from Rideau, I think, historically, it was very interesting, and we often clinically look at those individual longitudinal data points for each patient when we see them in clinic. And when you see a patient that has a peak forced vital capacity upwards of 2.5 liters, 2.7 liters, or greater, we had old natural history data that actually showed that the subsequent rate of decline was on the order of 4% per year, whereas those that have peak values less than, say, 1.5 liters lose about 10% per year. So those peak values obtained on the absolute forced vital capacity is really quite useful. I think the other thing we have to just caution us about is this whole issue of percent predicted parameters on pulmonary function tests. They're based on height measures, which are derived from ulnar length estimates, but height can be really quite impacted by steroid regimen. And we don't really know to what extent being short or stunted in your height actually impacts in a Duchenne patient the thoracic lung volumes. Those studies have never really been obtained. So I do think as you start to help manage young men with Duchenne dystrophy, certainly the absolute values can be very important in terms of impacting the management strategies that you take in terms of peak cough flow values and forced vital capacity values and so forth.
Great. Thanks, Craig. So the last two brief talks we're going to have are about approaches to try to understand the factors that are behind this variability. They're two data aggregation approaches that are designed to develop disease progression models. And these have all sorts of utility in clinical trials. They can make our trials a lot faster and better if we can develop these types of models. So I'll turn it over to James to talk about the first approach to this.
Okay, that's forward. Pointer.
So I'm going to talk briefly about the TAP collaboration, which is a trajectory analysis project, and what we're doing to understand phenotypic variation in Duchenne and why it matters for clinical trial design. So we've seen this figure a lot, and I think this is what has inspired many to try to understand what's driving phenotypic variation in Duchenne. This is showing, of course, meters walked over age, and each of the individual lines here is contributed by an individual boy. And the first thing that strikes us about this figure, of course, is it looks like there's a lot of variability. And what that means is if we try to characterize this population by just an average or just one trajectory over time, in some ways it doesn't cut it. In fact, if you look at the figure, almost no individual follows that average. So this is a lot of variability. If we want to start to pick it apart and understand what's driving this, then we're going to ask what is different about the boys that are following different trajectories. So if you start with something straightforward, like the walking distance when they entered the study, you'll get the figure that's shown here. So you see boys in green are walking over 400 meters at the start. Boys in blue are walking under 300, and the brown is in the middle. And you can see that this starts to explain some of the variability. The green trajectories are all closer to each other than they are to the others. But it's not quite there yet. Right? If you look at the group in brown, some of those are dropping down and losing ambulation quickly. In the blue group, some drop quickly, but others stay stable. So we'd like to know more about what is driving these differences. And so one thought is if we can objectively cluster or group together the boys that share similar trajectories over time, then we can go back and start to ask, what are the factors that drive these? And I think we've heard about a lot of those possibilities today, and we've seen a lot of promising evidence that different individual factors can all explain variability in these outcomes. So an important question is how can we start to put together these different factors, different predictive factors, steroid use, baseline function, genetics, if each of them explains a little bit, certainly combining them together should explain even more. And the reason this matters, as has been mentioned, is in a large part for clinical trial design and analysis. If there's a lot of variability that we can't explain, we're going to need bigger trials. They're going to take longer to recruit, longer to run, and they're going to be inherently more risky. And beyond the challenge with trials, there's also this issue of the averages that we see in research not representing individual patient experience. There can seem to be a disconnect there. As we can better explain variation, of course, the trials can get smaller, more predictable. And that also that also continues this pathway of better individualizing care. Right? If these patients are in different groups, and a physician over here has a patient in the blue group, and a physician over here has someone in the blue group, now that we know they're similar, you can communicate better about what works and what doesn't. You can do better studies about what works and what doesn't in those individual types. And we've heard that this matters for clinical trials, and I just wanted to quantify that a little bit so you can see how important this can be. So the bars here are showing how many boys would be needed in a hypothetical trial to detect a pretty good drug effect on 6-minute walk distance. And of course, every trial is different, depends on the drug and the setting, but this sort of follows the parameters that have been used for a lot of the recent trials looking at 6-minute walk. And the first thing I think to notice is if you go into this and you think your unexplained variation is at 50 meters for walk distance, that means if you were to predict for a boy, you can kind of get within 50 meters. You might design a trial that has 89 boys, and that would give you a good chance of detecting efficacy. However, first thing, if we're wrong about that unexplained variation, it's really more like 75 or 100, we're going to be in trouble. The trial's going to be underpowered, and we'll have a much lower chance than we'd hope of seeing if the drug really works. But this also shows that if we can understand, if we can explain more variation, we can stratify by it to reduce the number of boys that are needed to see efficacy. And from the numbers here, I hope you can see that the benefit can be quite dramatic. So how can we explain more variation? That seems like what we would all want to do. It's an ongoing process, and a lot goes into it. We've seen a lot of data on new biomarkers, and I think what is going to happen is these will kind of get disseminated throughout different clinics. More people will start measuring. They'll get incorporated into natural history data, into trials, and then people can bring that data back together and start to say, how do we leverage all of this new information to better predict outcomes? So in the TAP collaboration, we sort of asked, what can we do now with the information that's already available? What can we do to explain variation? So the mission of the TAP collaboration really starts with explaining that phenotypic variation in Duchenne, and then translating that into tools that can be used in drug development. And a core part of our mission is to make the insights available to everybody. And we're very keen on delivering near-term impact. So at year one, here's who we are and what we're up to. So currently there are 3 groups that have contributed natural history data, and these are all expert clinical collaborators around the world that we're working with. There are 5 different pharma sponsors and collaborators that have signed up. The patient advocacy groups, Cure Duchenne, PPMD, were instrumental in providing the seed funding and support and guidance to get this off the ground. And the last thing I want to say is that this is a collaboration, and collaboration is really what is helping us drive forward. We've already worked very closely with the drug sponsors who contribute not only funding, but insight into what's going to be helpful for them. And what we have seen so far has been very promising, and we're all very excited to continue leveraging the data within this collaboration, and stay tuned. Thank you.
Thanks, James. So we started out way behind, and it turns out they need time to turn this room over for the events tonight. So we're actually going to have to stop now, Enrique. I apologize. I think the first talk went 40 minutes instead of 20. So let's thank the panel and really appreciate your time.